Welcome, dear students. A warm welcome, dear students. Good evening, everybody. I'm Dr. Prathyusha. So quickly give me an update if you're able to hear and listen to me and see the screen properly. Please put a thumbs up if the audio and video is clear. Hi, Dr. Swami Rohitash. Hi, Akanksha. Hi, Akash. Hi, everybody. Okay, let us start the session. So as you all know, the topic for this live YouTube session is eponyms of ear. So eponyms are all proper names which are very difficult to remember. They're actually named on the scientist who discovered that particular fact or that disease or the sign. Okay. So the problem with eponyms is they do not give you any clue about what exactly is that disease because they're proper nouns. There is no hint in the name. So we have to devise a way to understand and remember that. Okay. So the plan for today's video is first, only in ear we are dealing. I would make a list of all the physiological eponyms of ear, and then let us move on to the more pathological signs, the signs involving diseases. Okay. So I hope everything is clear. All right. Okay. So your comments are super important to me. Keep commenting because that will help me decide the pace, direction, and other stuff. Okay. If you're able to understand, not understand, or if there are any questions, do not hesitate. Please put it on the comments. Okay. I would be reading parallelly and answer, and I will answer whenever needed. Okay. So without any further delay, let us begin the session. Eponyms of ear. And the first eponym that we are going to see is Arnolds nerve. Now quickly tell me, what is Arnolds nerve? Yes, it is the auricular branch of vagus nerve. Auricular branch of vagus nerve. Now Arnold is the name of the scientist. As you all know, stimulating the external auditory canal or the concha part of the pinna would give rise to cough reflex. And this is the scientist who discovered that. Arnold was the scientist who discovered that. And so this nerve, the auricular branch of vagus nerve, was nicknamed after Arnold, and it is called as Arnold's nerve. There's another name for this nerve, and that is Alderman's nerve. Both of them are the same. Okay, and this auricular branch of vagus nerve, it supplies the concha. In the pinna, we have an area called as concha. It supplies the concha and the corresponding area on the medial side of auricle or the pinna. Concha and the corresponding area on the medial surface of pinna. Not just this, it also supplies the external auditory canal. What part of the external auditory canal? The posterior wall and floor of external auditory canal. This is the area that is supplied by auricular branch of vagus nerve, and this is the nerve that is responsible for the cough reflex which occurs on stimulating these areas, either the concha or the floor of external auditory canal. I hope Arnolds nerve is clear to all of you. Are you able to read what I am writing? Is it legible, understandable? Okay, Tom Cruise, hi. Vegas is the right answer. Dr. Divya, Vegas is the right answer. Yes, very good. Okay, now let us move on to the next one on our list. And that is Bill's bar. What is Bill's bar? Now in my session, I'm not going to follow any one particular order. I'm not going to do it chapter wise or disease wise, because that is found in any book or in any notes. I want your mind to run through the entire ENT, entire ear at least, for this session, okay? So it is random, it will be jumbled, picking up from various topics, okay? So Bill's bar, what is Bill's bar? Where is Bill's bar present, anybody? Okay, let me give you a hint. Think about internal auditory canal, also known as internal acoustic meatus. What is internal acoustic meatus? It is a channel that connects the inner ear with the posterior cranial fossa. Internal auditory canal connects the inner ear with the posterior cranial fossa. And if you take a cross section of the internal auditory canal, it would look something like this. Can you all see the picture? This is the internal auditory canal and its cross section. Sundar Singh Shekhar, very good. It is a vertical bone segment. Sasuke Uchiha, yes, it is a vertical crest. Very good. Abhishek Patania, no, it's not about noise-induced hearing loss. Okay, now let us look at the structure of internal auditory canal. What are the structures present in the internal auditory canal? Now this is a transverse crest of bone. It is a transverse crest of bone that is called as the falciform crest. This crest divides the internal auditory canal into an upper chamber and a lower chamber, into superior and inferior quadrants. And in the superior part, again there is a vertical segment of bone. This is the vertical segment of bone that is called as Bill's bar. Yes? Okay. So the Bill's bar is dividing the internal auditory canal into anterior and posterior quadrants. Okay. Here we have anterior and this side is posterior. It might look like left and right to you, but no, it is not left and right. It is anterior and posterior. The Bill's bar is present like this. It is dividing the internal acoustic meatus into anterior chamber and a posterior chamber. And in between, transversely, we have the falciform crest. And below is the inferior chamber. Is that clear? Now let us look at the important structures that are passing through the Bill's bar, passing through the internal auditory canal. Okay. Now how to remember them is the challenge. We have 4 structures that have to be remembered. One is the facial nerve, one is the cochlear nerve, and next two are superior and inferior vestibular nerves. Facial nerve, I'll give you a tip and technique to remember that. Facial nerve, as we all know, supplies face. and face is on the anterior side. Yes? So, facial nerve is occupying this quadrant. Here is the facial nerve. This is the facial nerve. And below, in the inferior segment, we have cochlear nerve, the 8th nerve. 7 comes before 8 and 7 is placed on top and 8 is placed below. And then the vestibular nerves, which are concerned with the balance, are present in the posterior quadrant. And it is very simple. Superior vestibular nerve is above and inferior vestibular nerve is below. This is superior vestibular nerve and this is inferior vestibular nerve. Now with this, I hope you will always remember all the structures present inside the internal acoustic meatus. Yes? All good? Able to remember? Facial nerve and 8th nerve. 7 comes before 8. So 7 is on top and 8 is below. And these two are on the anterior side. And vestibular nerves, superior and inferior, are present on the posterior side. Now, why are we studying so much about the Bill's bar, so much about the internal acoustic meatus? Why this special attention to internal acoustic meatus? Anybody? What is the clinical significance of studying this in such detail? Any clue, anybody? Yes. One of you have rightly answered. Very, very good. It is because the acoustic neuroma, also known as vestibular schwannoma, it originates in the internal acoustic meatus. This tumor arises from the vestibular nerves that are present in the internal acoustic meatus. From there, it erodes the bone and then it reaches the cerebellopontine angle. We know acoustic neuroma as a tumor of cerebellopontine angle, but it actually originates from the internal acoustic meatus, and that is why understanding the internal acoustic meatus and all the structures present inside it, including Bill's bar, is very important to us. Okay? Is everything about Bill's bar clear? So let me move on to the next test, and that is binge test. You can also call it Bing test, and I called it binge for a reason. Okay? Honey, very good. The acoustic neuroma causes mass effect on the 7th and 8th cranial nerves. Yes. What is Bing test? Whenever it comes to tuning fork tests, everybody learns about Rennie's and Weber's with a lot of enthusiasm. And absolute conduction also, fine, we sometimes learn. But after that also there are 3 more tests, and Bing is one of them. A neglected test, right? And that makes it important for your exam. Anything that we neglect is the first question in the exam, yes? So what is Bing test? It's one of the tuning fork tests. I have already told you. Now, if you want to extract anything from your memory in the exam hall or suddenly when somebody asks you, you should always have a thread of story that links you to the concept, okay? And as much as possible, try to relate it with the name of that test, okay? Now, this is Bing. I said binge. What does the word binge remind you of? Binge watching something, binge eating disorder. Yes, binge is something that is done continuously without an interruption. And this Bing test is exactly the opposite of that. Sound is continuously traveling via the external auditory canal, and in Bing test what we do is we open and close the external auditory canal by pressing on the tragus. That is what we are doing in Bing's test. And why do we do that? Because we are trying to check the bone conduction and the effect of occluding the ear canal on hearing. What is happening to bone conduction when we occlude the ear canal and when we open the ear canal? That is what we are trying to check in Bing's test. Okay. So Bing's test is about opening and closing the external auditory canal and checking that effect on bone conduction. So let me explain what happens in two scenarios. In a patient with sensory neural hearing loss, when you're checking bone conduction, when the ear canal is occluded, the patient hears louder. The patient hears the sound louder. Why does that happen? Now the patient is having sensory neural hearing loss. And when you occlude the external auditory canal, the ambient noise is not present. And so his bone conduction becomes better. He is only able to appreciate the tuning fork sound now. There is no external noise because you have closed the external auditory canal. So his hearing becomes better. Okay? And he hears softer when the canal is open. And this is said to be Bing's positive. Now, the another scenario is conductive type of hearing loss. A patient with conductive type of hearing loss will appreciate no such difference. No difference. Because even if the canal is closed or is it open, when there is conductive type of hearing loss, the patient cannot appreciate any change. And so, here Bing is said to be negative. Is this clear? Did everybody understand Bing's test? How to recollect Bing's test? Open and close the external auditory canal alternatively by pressing on the tragus. That is what we are doing. And the rest of the story, you can automatically extrapolate in the exam. Yes? Should I move on to the next eponym? All good? Fine. The next eponym that we are going to see, okay, for a change, I'll not give you an eponym, I'll give you a question. Okay? Can you all look at the question that is present on the screen? Let me read the question for you. A 45-year-old male patient presents with complaints of sudden episodes of vertigo that is precipitated by loud sounds, and there is on and off hearing loss. Sudden episodes of vertigo precipitated by loud sounds, on and off hearing loss, plus there is a sense of fullness in the ear. Electrocochleography shows summating potential is to action potential. That is, the ratio between summating potential is to action potential is more than 30%. Looking at this question, it appears as if it is dropped straight from the textbook. The hints are so clear. And when you see such question in an exam, you feel elated and happy. It feels like this is what I've been preparing for. Yes? But the examiner will puncture your happiness with the next statement by telling you diagnosis of Meniere's disease is made. You don't have to do anything. The diagnosis is already made. First disappointment. Okay. Then you're at least expecting he will ask you something about the treatment. There is intractable vertigo even after medical therapy. And so endolymphatic surgery is planned. Now he has not given you that choice also. He is not giving you that choice also. Endolymphatic surgery is also planned. And now the question is, what is the surgical landmark to identify endolymphatic sac? Okay. What is the surgical landmark to identify the endolymphatic sac is the question. Anybody quickly? Now, if you are in front of me, I'll give you a chocolate if you can answer this question. Nobody has answered. Sasuke Uchiha, please try. Honey, it's not schwannoma. The diagnosis of Meniere's is already made. I hope that is clear. All the signs of Meniere's disease are absolutely present. There is sudden episode of vertigo. It is precipitated by loud sound. There is fullness in the ear, on and off hearing loss. Everything straightly pointing towards Meniere's disease. Okay? And even you have a clear-cut sign. Electrocochleography, SP is to AP more than 30%. That is a straightaway hint. Okay. And then in the treatment also we have come up till endolymphatic surgery. Nothing else has worked for the patient and endolymphatic surgery is planned. Now how to identify endolymphatic surgery is the question. Very good, Sundar Singh Shekhar. It is Donaldsons Line. Very, very good. Now why I've given a question like this is because these are the questions that are meant to trick you. Now you have already understood it's Meniere's disease, and the entire chapter of Meniere's disease is running in your mind. It's you're thinking of everything about Meniere's disease, the clinical features, etiology, pathophysiology, treatment, diagnosis, everything. But this Donaldson's line is somewhere that lies in anatomy, and the examiner is guiding you to think all about Meniere's disease while the answer to this question is lying elsewhere. Yes. And these are the type of questions that are asked in the exam just to stump you. Okay. So we are going to learn about Donaldson's line, and that is why I've put this question. I hope everything pertaining to the question is clear. Very good, Sasuke Uchiha. It is Donaldson's line. Internal medicine. Okay. So next we are going to study about Donaldson's line. What is Donaldson's line? It is a landmark to identify the endolymphatic sac, as you just understood. The endolymphatic sac lies just inferior to the Donaldson's line. But where is the Donaldson's line? That is the question. Now, this Donaldson's line is an imaginary line. After you studied so much about it, you understand that it is somebody's imagination. Okay, but it is actually very useful. Now, this imaginary line passes via the lateral semicircular canal to posterior semicircular canal. It bisects the posterior semicircular canal. It is just a simple line, a straight line that is passing from the lateral or the horizontal semicircular canal to the posterior semicircular canal. Okay. Now, in a question pertaining to Donaldson's line, where is Donaldson's line or how it is or showing you a picture, all that is not important. You should understand that it is a landmark for endolymphatic sac. Okay. This is the most important statement here. And that was our question, right? It is a landmark for endolymphatic sac. Are you able to understand? All good? Fine. Let us move on to the next eponym, and that is Pike maneuver. What is this maneuver? It is a clinical test that is done to assess vestibular function. It is a test that is done to assess vestibular function. It is a diagnostic test, and it is particularly useful when a patient complains of vertigo in certain head positions. Now, there will be patients who complain of vertigo in a particular position. Suppose they're lying on the bed with their head turned towards one side, they experience vertigo. Or every patient has some particular peculiar position, and every time they go into that position, that causes vertigo in them. Okay? And this test is particularly useful in such people, mostly for posterior type of benign paroxysmal positional vertigo. To identify posterior canal benign paroxysmal positional vertigo, this test is useful. Okay, it differentiates peripheral lesion versus a central lesion. In the causes of vertigo, you have peripheral lesions and central lesions, and this test differentiates between both of them. Okay. Roy the old gamer, this is not to reposition the otoliths if displaced. This is purely a diagnostic test. I'm coming to that. Okay, the idea of the session is just to understand what is what and how to remember them. Okay, I'm not going into the detail of any disease or any topic. All right. And the next in the list is Epley's maneuver. What is Epley's maneuver? What is Epley's maneuver? Anybody? Epley's maneuver is the treatment for the above condition. It's a treatment maneuver. For what? A posterior canal BPPV, benign paroxysmal positional vertigo. This will reposition the otolith from the semicircular canal into the utricle. It will put the otolith back into the utricle. And in 80% of the patients, a single attempt of Epley's maneuver will cure them of the disease. Okay? Harihar and Hari, very good. It is treatment for BPPV. Now, how do you remember what is diagnostic and what is the treatment? D for D. Dix Hall pipe is a diagnostic test. If you remember one, the other is automatic. Yes, if Dix Hall pipe is diagnostic, Epley's is treatment. No confusions? Okay, let's move on to the next one. And next in our list is foramen of Huschke. First chapter of ENT, first chapter of ear, first lesson external ear, first structure, okay, second structure, external auditory canal. This comes in the anatomy of external auditory canal. What is foramen of Huschke? It is a deficiency in which part? Bony part of external auditory canal. In the bony part also, in the antero-inferior aspect. Antero-inferior part of Bony external auditory canal. Okay. This is foramen of Huschke, and this is usually present in children less than 4 years of age. And sometimes it also persists in adults. And why is this structure important? Because it can cause communication of infections to and from the deep lobe of parotid gland to the external auditory canal. This acts as a channel between the parotid gland and the external auditory canal, and infections from either of the structures will pass through this foramen of Huschke, and that makes it important for us. Okay? Now the next one after foramen of Huschke is fissures of Santorini. What are fissures of Santorini? I've put them one after the other, so it's obvious. These are deficiencies in the cartilaginous part of external auditory canal. And why is this important? For a similar reason, this fissure will provide a channel for the spread of infection from the parotid gland and also from the mastoid into the external auditory canal and vice versa. Any external auditory canal infection such as diffuse otitis externa can spread as much as into the mastoid and cause mastoiditis, or it can go into the parotid gland and cause an infection there. Why? Because of the fissures of Santorini. Because of the fissures of Santorini, the infections can spread. Now here you can easily understand fissures of Santorini is in the cartilaginous part and foramen of Huschke is in the bony part. Later on, after the session, 2 days later, 2 years later, in the exam hall, how do you remember? Now when similar looking names are put together, always make a way to remember. That will always work and it will stay and stick into your mind. Okay. Now the way I remember this is, cartilage starts with C, but it has S sound. Okay, anybody knowing the Indian languages? C has S sound, yes? S and Santorini. S and Santorini. So fissures of Santorini are present in the cartilaginous part. And foramen of Huschke, obviously the second one I told you. Whenever there are two things, remember one and the other you can extrapolate. Yes? And foramen of Huschke is present in the bony part. Santorini, cartilage. Is that clear? Will you remember this now? Forever? Alright. Let us move on to the next one, and that is Jelly's test. I have again come back to a tuning fork test. Jelly's test is also a tuning fork test. And what is Jelly's test? Jelly's test examines the effect of increased air pressure on external auditory canal on hearing. You will cause pressure changes in the external auditory canal and see that effect on hearing. That is Jelly's test. So normally when the air pressure is increased in the external auditory canal, what happens is the tympanic membrane and the ossicular chain will move inwards. They are pushed inwards. And when the three ossicles are pushed inwards, the intralabyrinthine pressure will increase. And when the intralabyrinthine pressure increases, it will cause immobility of the basilar membrane. Basilar membrane is present inside the cochlea. On the basilar membrane, the organ of Corti is situated, right? And when the intralabyrinthine pressure increases, the basilar membrane cannot move, and that will cause a decrease in hearing. So in normal individuals, When air pressure is increased, what will happen? There is decrease in hearing capacity. And we call this as jelly positive. And when will this not happen? When the air pressure that you are increasing in the external auditory canal is not transmitted into the inner ear. When will that not be transmitted? When there is some disruption somewhere in the pathway. That is ossicular discontinuity or ossicular fixation. When the ossicles are fixed and not transmitting the pressure inside, then also this effect will not be seen, or there is some discontinuity in the ossicles, then also this effect will not be seen, and that is called as Jelly's negative. Very good, Sundar Singh Shekhar, very good. It is otosclerosis is the disease where Jelly's test is negative. The most important clue that an examiner will give you in a case of otosclerosis is Jelly's test negative. Jelly's negative, think about otosclerosis. Why? Because in otosclerosis, the foot plate of stapes is fixed. And when the foot plate of stapes is fixed, it cannot transmit the pressure. Akash, you want me to repeat again? Okay, sure. Repeat the mechanism. See, it's very simple. When the air pressure is increased in the external auditory canal, first of all, how do you increase the air pressure? You can use an instrument called as Siegel's speculum. Siegel's speculum is an instrument that will help you cause air changes. You can increase the pressure or decrease the pressure in the external auditory canal. When you increase the pressure, what happens? The tympanic membrane is pushed inside, and attached to the tympanic membrane, we have malleus. And attached to malleus is incus, and incus to stapes. So these three ossicles are also pushed inside, and this will cause the intralabyrinthine pressure to increase. That is, the inner ear pressure will increase. When the inner ear pressure increases, the basilar membrane will not move. It becomes immobile. So when the basilar membrane is not moving, the hearing capacity is reduced. This is normal. Air pressure is increased, hearing decreases. When will this mechanism break? When will this not happen? When the high air pressure that you are creating in the external auditory canal is not going into the inner ear. When will that not go? In two situations. One, when the ossicular chain is disrupted, discontinued, or there is fixation of ossicles. Stapes fixation, classically seen in otosclerosis. So Jelly's test is negative in otosclerosis, and this is a potential exam question. Sorry. Jelly's negative, otosclerosis. Is that clear? Let me move on to the next eponym, and that is Habenula perforata. Ever heard of this term? Habenula perforata. The cochlear nerve is the nerve of hearing, as you all know. It has to supply the hair cells of organ of Corti. And how does it reach the inner ear and reach the organ of Corti? It passes through small openings that are present in the osseous spiral lamina. Cochlear nerve passes through small openings present in the osseous spiral lamina. And these openings are called as Habenula perforata. Why are we learning this? Because in some individuals, these are normally small, yes, they're small openings. But in some individuals, these openings could be wide and large. If these openings are wide, it can cause peri-lymph fissure in a stapes surgery. When you're performing stapes surgery, if these openings, perforations are huge, the peri-lymph that is present inside the cochlea will come out. It will gush out in individuals where the habenula perforata are wide. That is the importance of these. So, before undertaking a stapes surgery, you should be aware of this concept that there are openings called habenula perforata and sometimes they could be big, and if at all those openings are wide, it can cause problems to you while performing the surgery. And how will you avoid this? You can look at these wide perforations on a CT scan. Before performing a surgery, if a diagnostic CT scan is done, if at all the patient has wide habenula perforata, it can be identified. That is about habenula perforata. Okay. Clear? Is that clear? Is everything good? Okay. Let us move on to the next term, and that is Hertel's fissure. What is Hertel's fissure? Hertel's fissure is an embryonic remnant that connects the subarachnoid space to the middle ear. It is a communication between the subarachnoid space to the middle ear. It's an embryonic remnant. And this fissure is present anterior and inferior to the round window. On the medial wall of middle ear, we have a round window. Yes, it's also called as the secondary tympanic membrane. Anterior and inferior to the round window, this Hertel's fissure is present. Normally, Hertel's fissure is obliterated, but in some people, it could be present. Now, whenever an abnormal communication like this is present, there are two things. One, as we have seen in fissures of Santorini and foramen of Hershke, there is a chance for spread of infections. Because of Hertel's fissure, meningitis can occur even with normal otitis media. Middle ear infection is spreading into the brain, spreading to the meninges and causing meningitis. Yes, this is one problem. And now, because that is an abnormal communication, this can be a source of congenital CSF otorrhea. What is present in the subarachnoid space? Cerebrospinal fluid is present. And because of this communication, the CSF can come out into the middle ear and it can cause CSF otorrhea. Very good, Roy, the old gamer. There is passage of infection. Next, let us move on to the next structure, and that is Jacobson's nerve. What is Jacobson's nerve? Anybody? What is Jacobson's nerve? It is the tympanic branch of glossopharyngeal nerve. This supplies the medial surface of the tympanic membrane and also the entire middle ear, the mucosa of middle ear, plus the eustachian tube also. That is Jacobson's nerve. Now it is all clear, but in the exam, suddenly if you see Arnolds nerve and Jacobson's nerve together, can you differentiate what is what? That's why I've put them a little apart so that you can recollect. Arnold's is a branch of vagus and Jacobson is a branch of glossopharyngeal nerve. How do we remember? Same logic that we have used to remember Santorini and Hushke. J sound and G sound are similar. Yes, J and J. Although we call this glossopharyngeal and not glossopharyngeal, but still you can remember as J sound. Glossopharyngeal, Jacobson's. So automatically the other, Arnold, is for vagus. You can also remember it in another way. A, if you reverse, it is V. A and V are close. And Jacobson and glossopharyngeal have the same sound. Okay? Now, will you remember this forever? So that's all about Jacobson's nerve. Next, let us move on to the next eponym, and that is coroner's septum. What is coroner's septum? Now, if you know, the temporal bone develops from the petrous part and the squamous part. Yes? And in between the petrous part and the squamous part, there is a petrosquamous suture. And this petrosquamous suture sometimes will persist as a bony plate. And that is your coroner's septum. The bony plate, which is petrosquamous suture, if present between the petrous part and the squamous part, then that is called as coroner's septum. And why is coroner's septum important to us? Because this coroner's septum will separate the superficial air cells from the deep air cells. In the mastoid antrum, you have air cells. And this coroner's septum, if present, will separate the superficial squamous air cells from the deep petrosal cells. And when you're doing mastoidectomy, you have to be aware of the structure called as coroner's septum and understand that below the coroner's septum also mastoid is present and some air cells are present. And only when you remove the coroner's septum, you can go deep into the mastoid and complete your mastoidectomy. That is the importance of coroner's septum. I'll show you a picture of coroner's septum, how it looks on a CT. This is a CT scan and I'll tell you how to identify. All the air cells that you're seeing here, this is your mastoid antrum. Yes? And in between these two, this crest of bone that you're seeing is coroner's septum. I will erase the marking so that you can once again appreciate the thin plate of bone that is coroner's septum. Is everybody able to see the coroner's septum? Yes, Akash, we have to remove beyond the septum because air cells are present beyond the septum. And when you're doing a mastoidectomy, we have to completely clean the entire structure. That is the importance of coroner's septum. And doing a CT beforehand will help you identify the presence of coroner's septum. You have to drill through the coroner's septum, remove it and go beyond. Okay. Next after corner's septum is Machivands triangle. Another very famous surgical landmark. I'm sure all of you know about Machivands triangle. But the super intelligent people would know about Machivands sign, also called as Machivands sign, that is seen elsewhere. I'm not going to tell its answer. It's not even an ENT, it is in some other subject. Put it down in the comments if you know the answer. Okay, meanwhile, I'll explain about Machivands triangle. Machivands triangle is a surgical landmark. For what? It's a surgical landmark to identify the mastoid antrum. Okay, and this Machivands triangle is also called as suprameatal triangle. And also when there is acute mastoiditis, tenderness can be felt over this Machivands triangle. If you can locate the Machivands triangle and press over there, the patient will experience tenderness in mastoiditis, acute mastoiditis. Now you have to know the boundaries of Machivands triangle. Can you all look at the picture? It's a triangle, so there are three boundaries for that. One is the temporal line. This is the temporal line. Temporal line is where the temporalis muscle is attached to. Okay, that is the temporal line. Next, the posterior-superior segment of bony external auditory canal forms the second boundary. Now, can you all see this external auditory canal? This is the external auditory canal. And I said the posterior-superior part. This is the posterior-superior part. So, this forms another boundary. Yes. And the third boundary is formed by a line that is drawn as a tangent to external auditory canal. And this is the external auditory canal, as you know. And if I draw a tangent from this, this is the tangent. You all know what a tangent is, right? From a circle, we draw a tangent like that. It lies perpendicular to the radius and it touches the circle only at a single point. That is a tangent. Little bit of mathematics, okay? Geometry. We still remember even after becoming doctors. So this is the Machivands triangle. Yes? Is the suprameatal triangle or Machivands triangle clear to everybody? And you also know why that is important? Because it is a surgical landmark for mastoid antrum. Yes? Very, very good, Roy the old gamer. Machivands sign is seen in congenital hydrocephalus where the skull becomes eggshell-like and it will give a crackling sound on tapping it. Did you go and search for the answer and come back? Or were you listening to Machivands triangle? Yes? Okay. Next, let us move on to another structure, that is ostman's pad of fat. What is this ostman's pad of fat and where do you see it? The name says it is a mass of fatty tissue. But where is that present? Quickly answer me. I will show you a picture. Now can you tell me where is ostman's pad of fat present? This is fat. This is the ostman's pad of fat. Where is that present? No answers. Very good, Sasuke Uchiha. It is eustachian tube. Now, this ostman's part of fat is present on the lateral side of the membranous part of eustachian tube. This is the eustachian tube, and on the lateral side, there is this mass of fatty tissue that is called as ostman's pad of fat. And this fatty tissue will help to keep the eustachian tube closed. The eustachian tube always is closed and sometimes it opens. Intermittently it opens. When we swallow or sneeze or yawn, the eustachian tube opens. And this ostman's pad of fat helps to keep the tube closed. And why should the tube remain closed? To protect the eustachian tube and also the middle ear from the nasopharyngeal secretions. Otherwise, there will be reflux of the nasopharyngeal secretions into middle ear. And for that, the tube has to, and to prevent that, the tube has to remain closed. And the ostman's pad of fat helps to keep the tube closed. That is about ostman's pad of fat. Helps to keep the eustachian tube closed. Okay. Next in our list is a space that is called as Prosax space. What is Prosax space? What is Prosax space? Roy is in the class. Okay. Answer Prosax space. I'll show you a picture of Prosax space. Got a hint? What are you seeing here? Tympanic membrane and middle ear ossicles. The Prosax space lies somewhere here. This is the Prosax space. Now, when you look at this picture, there are high chances that a student would assume this to be Prosax space, but no, that is not Prosax space. This small tiny structure over here, this is Prosax space. Okay? And why is Prosax space important to us? Because this will limit the spread of infection to other compartments. The high fibrous compartment, and it will try to limit the spread of infection. That is first point. And second point is, it is the most common site of attic cholesteatoma formation. And for these two reasons, Prosax space is important to us. And let us see the boundaries of Prosax space. Superiorly, we have lateral malleolar fold. Medially, what is present? Look at the picture once again and answer me. Laterally, there is the upper part of tympanic membrane, that is the pars flaccida, and also this bony crest, a little bit of the bony crest is present, which is called as scutum. And on the other side, what is present medially? It is the neck of the malleus bone. Neck of malleus bone is present. And inferior to the Prosax space, we have the lateral process of malleus. This is the lateral process of malleus that is present. I'll write that down for you. Medially, what do we have? Neck of malleus. Laterally, there is the pars flaccida plus a bony crest which is called as scutum. And inferiorly, there is the lateral process of malleus. This is about Prosax space. Yes, many of you have answered correctly. Very good. I'm moving on to the next structure, and that is Pulitzer test. It's named after Pulitzer. What is Pulitzer test? It is a eustachian tube function test that is done to see the patency of the tube. The Pulitzer bag has a tip called as the which is olive shaped, and this tip is introduced into the nostril. Now, whichever side we want to check the patency, suppose I want to check the right ear eustachian tube patency, I will introduce the tip of the Pulitzer bag into the right nostril, and I will close the other nostril, and then I will apply pressure onto the Pulitzer bag so that air moves over there. And a high pressure is created into the nasopharynx so that the tube is opened and the air moves via the eustachian tube into the middle ear. You also ask the patient to swallow so that will also help in opening the tube. And if the tube opens and if this air moves on to the middle ear, how will you verify? Okay, until here, this shows that the tube is patent. But how to verify the same? By checking the tympanic membrane with an otoscope. When air enters the middle ear, the tympanic membrane will bulge outside. That is a sign that the eustachian tube is patent. That is Pulitzer test. It is used to check the eustachian tube patency. Is Pulitzer test clear to everybody? Okay. Next in our list is Reisner's membrane. What is Reisner's membrane? If you take a cross section of the cochlea, it would look something like this. This is the scala vestibuli. This is the scala media. And this is scala tympani. The structure is actually complete here. Okay. So cochlea is divided into three compartments: scala vestibuli, scala media, and scala tympani. And the scala media or the cochlear duct is triangular in cross section. It is triangular in cross section. And if you look at the three boundaries of this cochlear duct, the one at the base is called as basilar membrane, and this is called as Reisner's membrane. Now, the Reisner's membrane is separating scala media from scala vestibuli. That is Reisner's membrane. Okay, and the basilar membrane is separating scala media from scala tympani. And the third boundary, just for the sake of completion, I am telling you, is stria vascularis. Okay. Is Reisner's membrane clear to everybody? On the basilar membrane is present the organ of Corti. Okay, I have a mnemonic from Roy. R is equal to roof and R is equal to Reisner's membrane. When base is called basilar membrane, roof is called as Reisner's membrane. R for R. Very good, thank you. Is Reisner's membrane clear to everybody? Next, let us move on to another structure that is called as fossa of Rosenmuller. Rosenmuller's fossa. What is Rosenmuller's fossa? First of all, this fossa is present in the nasopharynx. Okay. It is a space that is present behind the torus tubarius. It is present behind the torus tubarius in the nasopharynx. And why is fossa of Rosenmuller important to us? Because it is the most common site of nasopharyngeal carcinoma. When you're suspecting nasopharyngeal carcinoma in any patient, you have to look into the fossa of Rosenmuller. And the fossa of Rosenmuller is not straight staring into your face. It is present behind the torus tubarius. So you have to be aware of it and search for the fossa of Rosenmuller. Look at this picture. This is an endoscopic view of the nasopharynx. Can you see the various structures? This bulge that you're seeing is the torus tubarius. Okay? And here is the eustachian tube opening. Now behind the torus tubarius, this fossa that you're seeing here, this area is the fossa of Rosenmuller. Neat PG question. You will be given a picture and asked to identify that structure which is the most common site for nasopharyngeal carcinoma. So we have to know that it is fossa of Rosenmuller, and second step we should be able to identify fossa of Rosenmuller. Okay? Alright. Next structure after fossa of Rosenmuller is, it's not a structure actually, it is a test, and that is Rinne's test. All of you know about Rinne's test? The first tuning fork test. And the speciality of Rinne's test is, it is the only test out of the tuning fork tests which compares air conduction with bone conduction. Yes. In the rest all tests, we are only checking for bone conduction if you carefully observe. It's only Rinne's where air conduction is compared with bone conduction. So if you look at an image where the tuning fork is placed in front of the ear of the patient, close your eyes and mark it as Rinne's test. Okay, that is Rinne's test. And you all know the concept of Rinne's test, but let me quickly revise. In a normal patient, air conduction is better than bone conduction. Yes, why? Because when the sound is traveling via the middle ear, there is amplification of sound by the middle ear ossicles. So air conduction is better than bone conduction in a normal patient. In a normal person, not a patient. In a normal person, air conduction is better than bone conduction. And this is called as Rinne's positive. But in a patient with conductive type of hearing loss, the patient will say bone conduction is better than air conduction. And this is said to be Rinne's negative. Okay? Very quickly and briefly about Rinne's test. And after Rinne's test, let us look into another tuning fork test, that is Squabach's test. In Squabach's test, the bone conduction of patient is compared with bone conduction of examiner. In absolute bone conduction test also, the bone conduction of patient is compared with the bone conduction of examiner. How do you differentiate these two tests then? Here, the external auditory canal is not occluded. When the external auditory canal is not occluded, there is some amount of air conduction also. Absolute bone conduction means you are only checking for bone conduction. But in squabaks, because you're keeping the EAC open, although you're checking for bone conduction, the effect of the ambient noise is present via air conduction. So, when you ask the patient and compare the results with the examiner, in a patient with conductive type of hearing loss, squabaks is heard longer than the examiner. The examiner says, I've stopped hearing, but the patient will still continue to hear. His bone conduction is even better than the examiner in conductive type of hearing loss. And in sensory neural type of hearing loss, it is less, shorter than the examiner. The patient will stop to hear first before the examiner. This is about Squabaks test. And if you have observed, we have learned about so many tuning fork tests. Let me quickly revise them for you. Binge. How do you remember? You're not allowing binging of sound. You're closing and opening the external auditory canal. Jelly. In jelly, what you're doing? You're changing the air pressure in the external auditory canal. Jelly is negative, otosclerosis. Rini, you know, is comparing bone conduction and air conduction. Normally, air conduction is better than bone conduction and Rini is positive. But in a patient with conductive hearing loss, Rini is negative because bone conduction is better than air conduction. Then we have learnt about Squabaks test, where bone conduction of patient is compared with bone conduction of examiner. In sensory neural hearing loss, the patient's hearing is better than the examiner, longer than the examiner. And in conductive hearing loss, the patient hears for a longer time. And in sensory neural, the patient hears for a shorter time than the examiner. Is it clear? Okay. Sasuke Uchiha, do you want an instruments class? Sorry, I cannot understand the language in which you are communicating. Let us move on to the next term, and that is shrapnel's membrane. Shrapnel's membrane. What is shrapnel's membrane? This shrapnel is actually the name of a scientist who did extensive research on ear anatomy. He was an anatomist and he did extensive research on ear anatomy, and he was the one who described the structure of tympanic membrane. And so a part of the tympanic membrane is named after him. As you know, the tympanic membrane has two parts, pars tensa and pars flaccida, and pars flaccida is also called as shrapnel's membrane. Okay, this pars flaccida lies opposite to the attic part in middle ear. Okay, it lies opposite to attic. Now see, everybody knows about pars tensa, pars flaccida and the entire anatomy of tympanic membrane, but suddenly in the exam sometimes what happens is, instead of giving pars flaccida, they'll give you shrapnel's membrane in the option. And that time your children get stumped. That is the reason I've put this, okay? Now another point that you have to know about pars flaccida is, normally the tympanic membrane has three layers: outer epithelial, middle fibrous and inner mucosal layer. And the middle fibrous layer is organized into various fibers: radial fibers, circular fibers and parabolic fibers. All this organization is present only in pars tensa. Okay, in pars flaccida, the middle fibrous layer is not organized into various fibers. It is not organized. Into various fibers. Okay. All good. Should I move on to the next test? That is Stenger's test. What is Stenger's test, anybody? I'll give you a clue. Just repeat the word Stenger many times. Stenger, 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 stranger, stranger. Where did it end up? Stranger. Yes. If you say Stenger for 10 times, you will end up saying stranger. And what were we taught as kids? Never trust strangers. Yes? And as a doctor, whom you should never trust? Where is all this discussion leading to? You should either catch the hint or you should know what is Stenger's test and answer the question. Nobody? Whom should you not trust as a doctor? You should not trust the patient. If you don't trust the patients, it's very hard, Akash. Very, very good. Very good, Roy, the old gamer. You shouldn't trust malingerers. And this is a test to identify malingerers. Who are malingerers? Who feign an illness for some hidden benefits. Okay? And feigning deafness is very, very common among malingerers. Because it's hard to pretend to be blind, it's hard to pretend many other things, but it's very easy to pretend deafness. And so you will find a lot of malingerers in ENT OPD. Okay, not a lot, but definitely. Out of all the malingerers, I can tell you many are seen in the ENT department. Feigning deafness. And so we definitely need tests to identify deafness. Of course, now you have these objective tests like BERA, electrocochleography, and impedance audiometry and all. But even before that, there was a clinical test called a Stenger's test. Now, the concept of Stenger's test is very, very interesting. It is slightly tricky, so focus for some time, pay your attention to me and understand, okay? What we do in Stenger's test is, we take two tuning forks that are identical. Suppose I take a 512 hertz tuning fork. The second one also I will take 512 hertz only, okay? So, I will take two tuning forks with the same frequency that are identical. And with one fork, I will produce a higher intensity sound. That is a sound that is louder. Now, there is a principle in ear mechanism that says that, okay, I'll write the principle down for you to understand and, absorb that. When same frequency sounds of different intensities, okay, same frequency sounds of different intensities are presented to both ears, that is what we are doing, right? We are taking two tuning forks of the same frequency. One is louder and we are presenting it to both ears simultaneously. What happens is that only the ear which receives the louder sound will perceive it. Suppose 512, one side I'm giving a sound of 40 decibels and another side I'm giving a sound of 60 decibels. Only this ear which is receiving the 60 decibel sound will perceive it. This will absolutely not go into the ear. That is a principle that is present in ENT, okay? Only the ear which receives louder sound will perceive it. Is the principle clear to everybody? Is the principle clear to everybody? Because only if you understand the principle, we can understand the test. All right. Now just take the example. Same frequency sound. One is louder and one is less loud. And we are presenting it at a time to both the ears. Only the louder sound will be perceived by the ear. Now this ear will not hear anything. Only the ear which is receiving the louder sound will perceive it. That is the principle. Very simple. Okay. Now I'll tell you how to do the test. While doing the test, the patient has to be blindfolded. Okay. Now say this is our patient and he is blindfolded. Okay. And you're giving two identical sounds. And now let us say the patient is complaining of deafness in the left ear. The patient says he cannot hear in the left ear and he's deaf in the left ear. And when you present its sound, now what will happen? If it's a normal person, let us say, he will hear the sound in the right ear if it's a true patient. Yes, the left ear is deaf and you're presenting sounds. So when the left ear is deaf, he will automatically be able to hear with the right ear if it's a true patient. Okay? Clear so far? Next, if it is a malingerer, first time what you will do, you will again give 2 tuning forks, one with a louder sound, and the patient will answer something. He will say, I'm able to hear. Now, he has decided, the malingerer also decides he wants to feign deafness on the left ear. So, he says, I'm able to hear it on the right side. Then what you do is, you move one tuning fork closer to the ear. Okay? One side tuning fork, you move closer to the ear. The patient is blindfolded. He doesn't know what you're doing. Now, what happened when you moved the tuning fork closer to the ear? The loudness has increased. Yes, when the loudness increases, now both the tuning forks have the same frequency and one is louder than the other. What will happen according to our principle? Only the ear which receives the louder sound will perceive it. So, only this ear is perceiving the sound. Yes, but the patient is feigning deafness on this side. So, he cannot agree that he is able to hear sound on the left side. Whichever side he said he's not able to hear, we are making the sound that side only. We are increasing the intensity of sound on that side. Now, the patient can hear only on this side. He cannot hear anything on the opposite side. But he is acting deafness on that side, so he cannot agree to the fact that he is hearing. So, he will say, I am not able to hear anything. A malingerer will say no sound in such a scenario. What will a true patient say? A true patient is really deaf on this ear. Yes, but the right ear is working. Now, when both the ears are working, only one side the sound will be perceived. But if at all the patient is really deaf on this side, he will at least be able to hear this ear. He will be able to hear the sound coming from the opposite tuning fork. And a true patient will say, I am able to hear on the right side. Now, malingerer has both the ears functioning, so he can hear only on one side. And that side he cannot agree that he is hearing, so he will say no sound. No sound means malingerer. If there is real deafness, this ear is deaf and you have moved the tuning fork closer, but he is still not able to hear, but the opposite ear will still receive the sound and the patient will be able to hear on the other side. This is the concept of Stenger's test. Is that clear? It is slightly conceptual, slightly tricky, but if you understand this principle, you will be able to make out Stenger's test. Okay? Now, I'm not really sure if questions would be asked about the interpretation of the test in this detail. Nevertheless, I shared it with you because it's a very interesting concept. It's one of the few topics in ENT that requires you to, conceptually understand something. Otherwise, ENT is a very simple subject. It's factual. But rarely, once in a while, you get such conceptual understanding topics. So, I've explained it in detail, but one thing you must remember, Stenger's test used to identify malingerers. Stenger, if you say 10 times, it will become stranger. And do not trust strangers, do not trust malingerers. That's our rule for the day. Okay, let me move on to the next term, that is Trotman's triangle. Where is our numbering? 24. Trotman's triangle. Anybody, what is Trotman's triangle? I'll show you a picture of Trotman's triangle. Okay, before that, this is pars flaccida. I'm sure you know it, but still. Also called as shrapnel's membrane. Okay, now let us look at the Trotman's triangle. Now, Trotman's triangle is important because it forms a surgical approach to the posterior cranial fossa from the mastoid cavity. Okay. Now, there is a thin bone between the mastoid cavity and the posterior cranial fossa. And whenever there is a thin bone, there are two things, two clinical implications. One is that infection can spread from one structure to another structure. And second is you can use it as a surgical route. Okay, you can use that thin bone as a surgical approach. So, Trotman's triangle facilitates us to go into the posterior cranial fossa via the mastoid antrum. Now, to go into the brain, to perform any brain surgeries, there are various routes. And to go into the posterior cranial fossa, this is a good route. So, let us understand the boundaries of Trotman's triangle. Can you label any of these structures? This, what you're seeing here, it is the superior petrosal sinus. Okay. Superior petrosal sinus. And this structure that you're seeing here, it is sigmoid sinus. Okay. Now, these two structures along with the bony labyrinth, what you're seeing here is bony labyrinth. These three are forming a triangle. This is the triangle. Now, in anatomical terms, triangle means you should not expect a perfect equilateral triangle. Okay, anything close to a triangular shape is called a triangle. Okay. So, this is the Trotman's triangle. Superiorly, there is the superior petrosal sinus. Anteriorly, we have the bony labyrinth. Bony labyrinth is present anteriorly and the sigmoid sinus is present posteriorly. Is Trotman's triangle clear to everybody? Thank you, Suraj, that you have understood the topic. Can I move back to the notes from this picture if you have all observed the Trotman's triangle? Yes? Okay. Now, what is the importance of Trotman's triangle? It forms a surgical approach. It gives you a surgical approach to the posterior cranial fossa. From the mastoid. That is the importance of Trotman's triangle. And it is important to us because that's an MCQ. Yes. Next, let us learn about theories of cholesteatoma formation. Because lot of eponyms are present here. I will explain all of them. Now, what is cholesteatoma briefly? Squamous epithelium that has appeared in the middle ear. Normally, there is no squamous epithelium in middle ear, and if at all it comes, we call it cholesteatoma. From nowhere it has come. because normally it is not present. How did that squamous epithelium come into the middle ear is the question. Okay, that is the etiology of cholesteatoma. And when the etiology is not clear, there will be various theories that are trying to explain the etiology. And let us look at those theories. The first theory states that there could be some congenital cell rests. Congenitally only some squamous epithelial cells have been left behind, and later on they will proliferate and form cholesteatoma. That is one theory. There is another theory called as Whitmack's theory. Whitmack is the scientist who proposed this theory. According to him, the tympanic membrane is invaginating into the middle ear in the form of retraction pockets. Yes, we know that the tympanic membrane will sometimes form retraction pockets and it will invaginate into the middle ear. And during such invaginations, now because the outer side of tympanic membrane is lined by squamous epithelium, somewhere during those invaginations, the squamous epithelium is coming into the middle ear. That is Whitmack's idea of cholesteatoma. Okay. Then there is another scientist called as Rudy. He has a theory which is also called as basal cell hyperplasia. Now, according to him, what he says is, under the influence of infections, the basal cells that are present in the germinal layer, they will proliferate and they will lay down they will lay down keratinized squamous epithelium. The basal germinal cells, under the influence of infection, they will lay down keratinized squamous epithelium. According to Rudy. We have another theory that is given by Haberman. Haberman's theory. According to Haberman, the epithelium that is present in the external ear will grow into the middle ear through a pre-existing perforation. So Haberman's theory will work out only when there is a tympanic membrane perforation. If tympanic membrane perforation is there, especially a marginal type of tympanic membrane perforation, then via epithelial invasion, the epithelium from the external auditory canal will go into the middle ear and it will proliferate there and form cholesteatoma. That is Haberman's theory. It's also called as the theory of epithelial invasion. That is when there is a pre-existing perforation of tympanic membrane. The cells from the external ear are migrating into the middle ear and forming a cholesteatoma. That is Haberman's idea of cholesteatoma. And finally, we have the last theory, which is Sade's theory. Sade is the scientist who also gave grades for tympanic membrane retraction. Okay. So according to Sade, the middle ear mucosa will undergo metaplasia. It will undergo metaplasia. Just like how the respiratory epithelium undergoes metaplasia, just like how the esophageal epithelium undergoes metaplasia in GERD, Sade says that the middle ear mucosa is also undergoing metaplasia because of repeated infections. And so the columnar or cuboidal epithelium is getting converted, transformed into squamous epithelium and causing cholesteatoma. These are various theories of cholesteatoma formation. Did everybody understand? Please give me a thumbs up if all of you understood. Now, all said and done, the point is how to bell the cat, how to put the bell around the cat's neck, how to remember all these theories. Okay, I have a technique for you. SAID's theory. It happens when the body is sad. When will your esophageal mucosa undergo metaplasia? When there is constant exposure to the acids of the stomach. It is so sad that it will convert itself into another type. Okay. And when will the respiratory epithelium undergo metaplasia? Chronic smokers. The epithelium is so sad, it is not able to, stand the toxic chemicals that are coming. So finally, unable to fight, it will convert. So SAID is when the tissue is sad, it undergoes metaplasia. So SAID's theory is about metaplasia. Next, Haberman's theory. There is a word man. And men have this habit of peeping into perforations and looking into holes. So whenever there is a perforation, they peep and then they go into that. Okay? Now I know most of you will not agree with me. You will say, no ma'am, men do not have such habits. And that is exactly what I want you to argue with me. And this entire discussion will make you remember that Haberman has a man. And the theory is men will peep into tympanic membrane through the perforated tympanic membrane and go into the middle ear and cause cholesteatoma. Okay? Helps to remember? Yes. Rudy's theory is when you are very rude to somebody and that person is, a soft, gentle person, they cannot do anything to you and so you have been very rude to them. What will happen next? The person will go gain strength and come back to you. Basal cells will undergo hyperplasia because you are rude to them. How are you rude to them? By repeated infections. They will undergo hyperplasia and come back as a keratinized squamous epithelium. Now we have ways to remember 3 theories. If it doesn't match with anything, it is Whitmack's theory. Okay? Helps. The crazier the idea, the better it will retain. Okay? Let us move on to the next term, and that is, are we at 26? Yes. Toynbee's test. Toynbee's test is also one of the eustachian tube function tests. Okay? It is one of the tests that checks for the patency of eustachian tube. Now, generally for all eustachian tube function tests, say your Valsalva, polymerization test, catheterization test, any of these tests, what we are doing is, we create a high pressure inside the nasopharynx and push the air into the middle ear via the eustachian tube. And if you can see the air in the middle ear, we will assume and conclude that the eustachian tube is patent. Only then this air will come into the middle ear. Yes? But Toynbee has a different method of testing. He said, why always create positive pressure and push the air? Let us create negative pressure. Negative pressure is created in the nasopharynx and let us see what happens. Whenever there is negative pressure, it will suck the air. So now the nasopharynx is drawing air from the middle ear. So air is traveling from the middle ear into the nasopharynx. And how can you see this? The tympanic membrane will now move inwards. In Valsalva, polymerization and all those tests, the tympanic membrane bulged outwards. But in Toynbee's test, it moves inwards. You can see that by an otoscope. Okay, that is Toynbee's test. Now, how do you create negative pressure in the nasopharynx? You can just ask the patient to swallow while his nose is pinched. So all the air will go down, and then after a point negative pressure is created, vacuum is created, and that act as negative pressure. That is Toynbee's test. Very good, Sasuke. You have to swallow while pinching the nose. Now, how to remember this concept that it is negative pressure in Toynbee's test? Rest all eustachian tubes are creating positive pressure. Now, honestly, tell me, when you read this test for the first time, how many of you thought it was Tony B? Any of you thought it was Tony B, and then you looked at the letters again and thought, okay, it's not Tony B, it's Toynbee? Happened? His name is only reversed, and he reversed the concept also. Until then, people were doing positive pressure. He said, let's reverse it. Let's create negative pressure and see what happens. That is Toynbee's test. Okay? And the last one in this list is Weber's test. With Weber's, we complete all the tuning fork tests also. Now, Weber's is the only tuning fork test that compares both the ears. Okay? All tuning fork tests will check each ear individually. Only Weber's test will compare both the ears. Okay? What happens in Weber's test? Let us see. You take a tuning fork and put it on the vertex. In case of conductive type of hearing loss, the sound is lateralized to the worst ear. Lateralized to worst ear. Suppose the left ear is normal, right ear is having conductive hearing loss. Where will Weber's sound go to? It will go to the right ear. Suppose right and left, both ears are having conductive hearing loss. Hearing loss in left ear is 20 decibels. Hearing loss in right ear is 40 decibels. Where will the sound go to? Worse ear, towards the 40 decibels side. If at all the patient is having sensory neural type of hearing loss, then the sound is lateralized to the better ear. Because basically in Weber, we are checking for bone conduction. Whichever ear is better, that will receive the sound. Okay? With this, we have seen all the normal anatomical structures, tests, and various physiological things. Okay, until now, I have not discussed any pathological sign or any sign related to any disease. This is one part of the session, the first part of the session. Now, because you all have been listening patiently to me until now, I have a bonus tip for you that is not related to eponyms, but something else in ENT that is very troublesome. And you know what that is? It is 1/3, 2/3 rules. Okay. What is this 1/3, 2/3 rule? There are three structures. One is the external auditory canal. Next is the eustachian tube. And then is the external nose. Whenever you are studying their anatomy, something is 1/3, something is 2/3, something is bony, something is cartilaginous. How much ever you prepare, suddenly when you see, I can challenge you, it's always difficult to recollect that. Unless you have a way to remember, or you have learned only one thing, and the second one you just, try to extrapolate or extract. Okay? So let us devise a way to remember this once and for all. First, let us look into the external auditory canal. Okay? External auditory canal, outer 1/3 is cartilaginous. Okay? And the inner 2/3 is bony. How to remember? If you just touch your external auditory canal, you can feel the soft cartilage outside. Only inside it is strong, there is bone. Also, logically, if you think, the middle ear and all is made up of bone. Outside you just have cartilage. So the structure connecting from cartilage to bone, you cannot have bone cartilage inside and bone outside. Yes. So outside is cartilage and inside is bone. Only outer 1/3 is cartilaginous, inner 2/3 is bony. Yes? Okay. And the measurements, the eustachian tube is, the external auditory canal is 24 millimeters in size. So the outer cartilaginous, which is 1/3, is 8 mm, whereas the inner 2/3 is 16 mm. This is about external auditory canal. Yes? Now eustachian tube. Reverse the situation. Eustachian tube also has a bony part and a cartilaginous part. Bone comes here and the fibrous membrane goes here. Okay. Now what is inside and what is outside? The eustachian tube is arising from the middle ear and it is coming forward into the nasopharynx. Do we have bones in the nasopharynx? Nasopharynx is also of mucosal structure, whereas the middle ear is bony. So that side, the posterolateral side, it is bony. And the anteromedial aspect, it is fibrous. It's a fibrous membrane. And the eustachian tube is 36 millimeters. So the bony part is 36 by 3, 12 mm, and this is 24 mm. Okay. And the external nose, luckily we don't have to remember the numbers because each one's nose size is different. Thanks to us. Thankfully, okay. But the nose actually I can tell you is very simple to remember. There's nothing much complicated. Even if you palpate, you can just see that the lower part is cartilaginous and upper part is bony. So upper part is bony and the lower part is cartilaginous. We just have two small nasal bones that constitute 1/3 and the cartilage is 2/3. Nose, there shouldn't be much confusion, but EAC and ET tube, you can try to remember it this way. Okay? So this is not an eponym, it's just a bonus tip for everybody who has been attending the class. Shall we move on to the pathological signs? All good so far? Now in the pathological signs, we shall discuss only 2 points. Where do you see that particular sign and what is it? We are not going to discuss the disease process in detail. Okay, only then we can discuss lot of signs and brush up everything at once. All right. So shall we do the pathological signs? No break, Akash. We can just get done quickly, no issues. Be with the same spirit. Let's move on. So the first one in our list is, any guesses? Now, although I said it's all jumbled, there has been an order that I'm following. If you see, I've been following the alphabetical order. And why did I do so? Because after the session, when you want to search for something, it's easy for you to navigate and locate that particular term if it's in the alphabetical order. Okay, so that's how we are going actually. All right, the first one is Aquino sign. Okay, please keep commenting so that I would know how it is going. Is the pace okay? Is the discussion okay? Any changes, any modifications? Or should I continue forward? Give me a quick thumbs up if all is okay. All right. So aquinosign is seen in glomus tumor. And what exactly is aquinosign? When you compress the internal carotid artery, the pulsatile tinnitus, which is seen in glomus tumor, will disappear. That is aquinosign. Disappearance of pulsatile tinnitus on compression of the internal carotid artery. That is aquinosign. Okay? Next. What is Bell's palsy? Everybody knows about Bell's palsy, right? Seen in element type of facial palsy. Lower motor neuron type of facial palsy. Now quickly, what are the features of Bell's palsy? Facial paralysis on one half of the face. Whichever side there is lesion, on the same side, the entire half, upper part, lower part, everything, you will have facial palsy. There are dry eyes, loss of taste sensation in the anterior 2/3 of the tongue on that side, and also there is hyperacusis on that side. The loudness of sounds is increased. Quickly about Bell's palsy, and for your satisfaction, I also have a picture showing Bell's palsy. The classical Bell's palsy, there is drooling of saliva, and the face is, deviated to one side. The angle of mouth is deviated, and all these muscles are paralyzed. The typical Bell's palsy face. Yes? Okay. Akash, you've commented 7. What is 7? Let's move on to the next term after Bell's palsy, and that is Battle's sign. What is Battle's sign and where is it seen? Battle's sign is seen when there is a fracture of the middle cranial fossa. Why are we discussing middle cranial fossa in neuroanatomy in our ear class? Because this fracture of middle cranial fossa appears as a bruising, a bruit on the mastoid area, bruit over the mastoid area or on the retroauricular area. So when you see a bruise in that area, it's actually indicative of something bigger, something dangerous. This occurs after a head trauma. I'll show you a picture of Battle's sign. This is how it looks. This is the ear, and you can see all over the mastoid area and also on the retroauricular place, there is a bruit that is present. Are you able to appreciate? Okay, that is battle's sign. How do you remember? When somebody has gone for a battle, what will happen? They will get injured and their middle cranial fossa can undergo a fracture, and all that you will see is a bruit over the mastoid area. Never ignore a bruit over the retroauricular or the mastoid area because it could be a sign of head trauma. Next in our list is Bezold's abscess. Okay, Bezold's abscess is, when is that seen? It is seen as a complication of mastoiditis. It is seen as a complication of mastoiditis. The pus, the infection that is present through the tip of the mastoid, it will break through the tip and it will present as a swelling in the upper part of the neck. In the neck area, you will see a swelling which is an abscess, and that is called as Bezold's abscess. You will see it in the upper part of the neck. It occurs as a complication of mastoiditis. Okay. There are many more abscesses. You can just look into this picture. Now, if you see an abscess like this in the upper part of the neck, it is Bezold's abscess. And if you see it behind the ear, we call it post-auricular abscess. And if it is above at the zygomatic process, we call it a zygomatic abscess. And all of them and many more that I will discuss henceforth, they can all occur as complications of mastoiditis. Okay. Is Bezold's abscess clear to everybody? Yes. Next in our list is Brown's sign. What is Brown's sign? Okay, I'll give you a hint. Brown's sign is also called as pulsation sign. Now somebody should quickly tell me, what is Brown's sign or pulsation sign? Where is that seen? At least that. No answers. Brown's sign is seen in glomus tumor. Aquino sign was also seen in glomus tumor, and Brown's sign is also seen in glomus tumor. When the glomus tumor is in the middle ear, you will see this. What exactly is Brown's sign or pulsation sign? When the pressure in the external auditory canal is increased via a Siegel's speculum, the tumor will pulsate vigorously and then it blanches out. Now, glomus tumor is a vascular tumor, yes? So that will pulsate vigorously and then it will blanch out. Because it pulsates vigorously, it's also called as pulsation sign. Yes, Bharat and Akash, could you have answered? So when the pressure in the external auditory canal is raised, you will see that the tumor pulsates vigorously and then it blanches. Okay. Next in our list is something called as Carhart's notch. What is Carhart's notch and where is it seen? Carhart's notch is seen in otospongiosis or otosclerosis. Both of them are same. And what is Carhart's notch? When you do a pure tone audiometry on a patient of otosclerosis, you will see a dip at 2000 Hz frequency in the bone conduction curve. On PT, that is Carhart's notch. Now, can any of you think of another condition where a dip is seen like this? Yes, you can see a dip at 4000 Hz in noise-induced hearing loss, NIHL. Now in NIHL you can see at 4000 Hz and you will see it in both air conduction curve as well as bone conduction curve. Okay. Now how to remember? Which disease 2000 Hz and which disease 4000 Hz? NIHL, how many letters? 4 letters. Dip is seen at 4000 Hz. Otosclerosis or otospongiosis, two alternate names. Dip is seen at 2000 Hz. Okay? Will you remember this? And you should also remember that this is seen in the bone conduction curve. Because in the exam, he might show you a graph and in 4 options, you will see air conduction at 2000 Hz, air conduction at 4000 Hz, bone conduction at 2000 Hz, bone conduction at 4000 Hz. Now 2000, 4000, we have no confusion, right? Now in 2000 also, it is seen in bone conduction curve in Carhart's notch. Okay? Why? Because otosclerosis or otospongiosis is a disease of the bone. The normal dense bone is being converted into a spongy bone. That way you can remember. It is seen in the bone conduction curve. Is it clear? Can I move? Can I move forward? Okay. I have a term called as crocodile tears. Have you heard of the idiom crocodile tears? When someone is fakely crying or shedding tears, we say, don't show your crocodile tears. It's an English idiom that is used. Because apparently crocodiles cry like that. But as a doctor, let me use a better term for this crocodile tears. That is gustatory lacrimation. What is gustatory lacrimation or crocodile tears? This occurs as a complication of facial nerve palsy. Very, very good, Bharat Vasan. What happens is there is unilateral lacrimation along with mastication. Whichever side the facial nerve has been damaged, that side there will be lacrimation whenever the patient is eating. The patient is not crying, but still tears are coming out whenever he is masticating. Why does that happen? After the facial nerve has undergone some injury and when it is regenerating, there is faulty regeneration of the parasympathetic fibers which are now supplying the lacrimal glands instead of the salivary glands. That will lead to crocodile tears or gustatory lacrimation. Now, can you all tell of another disease with a similar pathophysiology where the facial nerve gets injured and undergoes faulty regeneration and causes something else? Put it in the comments and I'll move forward meanwhile. After crocodile tears, we have an abscess called as Citylis abscess. Now, Cityli is another important scientist in ENT. We have Citylis abscess. We have Citylis angle, also called as the sinodural angle. We have Citylis forceps also, one instrument on him. Okay, so let us learn about Citylis abscess. Just like Basol's abscess, this is also a complication of mastoiditis. In basalt, the abscess was formed in the upper part of the neck, whereas in Cityli, it is found behind the mastoid, more towards the occipital bone. Okay, it is an abscess that is seen as a swelling behind the mastoid over the occipital area. Just behind the ear was post-auricular abscess. Cityli is even more behind. Okay. Very, very good, Bharat Vasan. I was referring to phrase syndrome. That is the answer for the previous question. Very good, Abhishek also. Gustatory sweating. Yes, let us learn about phrase syndrome further. For now, is Citylis abscess clear to everybody? Citylis abscess? Okay. Next in our list, we have a test called as Crowe-Beck test. What is Crowe-Beck test and where is it seen? Where is it done rather? It is done in sigmoid sinus thrombosis. Sigmoid sinus was forming one boundary for Trotman's triangle, if you remember, yes? Now in the sigmoid sinus, if there is a thrombosis, this is also called as lateral sinus thrombophlebitis. In this condition, we do this test. What is Crowe-Beck's test? When you apply pressure on the jugular vein of the healthy side, that will cause engorgement of the retinal veins or papilledema. You can check that with the help of an ophthalmoscope. Why does that occur? Because of sigmoid sinus thrombosis on the opposite side. That is important. This sigmoid sinus on the opposite side will cause retinal vein engorgement when you press the jugular veins and increase the pressure on the healthy side. That is Crowe-Beck test. Did you all understand Crowe-Beck test? Pressure on jugular vein on the healthy side will cause retinal vein engorgement. Or papilledema Why? Because of the sigmoid sinus thrombosis on the opposite side. Okay, you want me to explain again? Alright. Now, vein is basically collecting blood and we are putting pressure on that and occluding that vein. Now, whenever one channel is occluded, the blood will always try to deviate and follow an alternative path. But on the opposite side, sigmoid sinus, there is thrombosis. So that side also there is a block. Here you are occluding and that side there is already a block. So these retinal veins will now undergo engorgement. That is Crowe-Beck test. Is Crowe-Beck test clear now? Akash and Bharat? Next, let us move on to a syndrome called as Dandy syndrome. This Dandy syndrome is also called as oscillopsia. What is this? This is a difficulty to read hoardings or boards while walking. Strange, isn't it? Now imagine the person is walking on the road and he cannot read the hoardings. Why will this occur? When there is bilateral loss of vestibular function. If there is loss of vestibular functions on both sides, then the patient will experience this dandy syndrome. Okay? How to remember this? Dandi March, Salt Satyagraha. So imagine people were going for a Dandi March, and some of them who had dandy syndrome could not read whatever was written on the hoardings. Okay? Just a quick way to remember. Next, we have something called as delta sign. What is delta sign and where is it seen? Delta sign is also seen in sigmoid sinus thrombosis. This is actually a radiological sign. If you do a contrast enhanced CT, on a contrast enhanced CT scan in a patient with sigmoid sinus thrombosis, you will find a triangle with rim enhancement. That is, the border of the triangle is enhanced and the inner part, the center, has low density and a low density center. And where is all this seen? In the posterior cranial fossa. This is delta sign. Okay. Next, after delta sign, let us discuss about Frey syndrome, which some of you have already answered before. It is gustatory sweating. What's happening in Frey syndrome? There is unilateral sweating and flushing of the skin over the parotid area during mastication. This also occurs as a complication of facial nerve palsy, like our gustatory lacrimation. But this Frey syndrome is usually damaged during surgeries. Frey syndrome occurs when the facial nerve is damaged during surgeries. It will lead to sweating and flushing of the skin over the parotid area while lacrimation. Why? Because same concept. There is faulty regeneration where now the nerve has joined with the sympathetic sweat glands instead of the salivary glands. Sympathetic sweat glands of the parotid area. That is Frey syndrome. I think I can go ahead. Are you all with me? Okay. Next in our list is Grad-Inigo syndrome. Where is Grad-Inigo syndrome seen and what is it? It is seen in petrositis, which occurs as a complication of otitis media. The complications of otitis media are all very, very important, and petrositis is one such complication. In petrositis, we find this Grad-Inigo syndrome. Okay? Grad-Inigo syndrome is actually a triad of features. Now, before, let us see what exactly is happening in petrositis. The infection from the middle ear or from the mastoid, it spreads all the way to the petrous apex. And in that channel, it involves the sixth cranial nerve and the trigeminal ganglion. Okay. So the triad of features that we see in Grad-Inigo syndrome are sixth cranial nerve is involved. And what is the function of sixth cranial nerve? It supplies lateral rectus muscle, extraocular muscle. The lateral rectus muscle is supplied by the sixth cranial nerve. And when the sixth cranial nerve is involved, there is lateral rectus palsy. Okay. And also the fifth ganglion, trigeminal ganglion, is involved. That will lead to a deep-seated ear or orbit pain. And the patient will also have a persistent ear discharge. There is persistent ear discharge. These are the features of Grad-Inigo syndrome. Okay. It is seen in petrositis. Next, we have something called as Greisinger sign. What is Greisinger sign and where is it seen? This is seen in sigmoid sinus thrombosis. Now, we have already learnt 3 signs related to sigmoid sinus thrombosis. Yes, what are they? We have learnt about the Kroibeck test. We have learnt about the delta sign. And now this is the third one, Greisinger sign. Edema appears over the posterior part of the mastoid bone due to thrombosis of mastoid emissary veins. And that is called as Greisinger sign. Edema over the posterior aspect of mastoid bone due to thrombosis of mastoid emissary veins. That is Greisinger sign. Any confusion between Grad-Inigo syndrome and Greisinger sign? Grad-Inigo is a triad. You can remember it as a garden. Just one letter is exchanged. R and A. Why is that one letter exchanged? Because the patient is not able to see properly. Lateral rectus is paralyzed. So he has written interchanged R for A. And also his other eye is also paining. There is deep orbital pain. And there is ear discharge. These 3 are present in Grad-Inigo syndrome, which is seen in petrositis. And Greisinger sign is seen in sigmoid sinus thrombosis. It is an edema that appears. Okay. Can I move forward? Next in my list is Hitzlsperger sign. A very interesting sign. First, where is it seen? Hitzlsperger sign is seen in anybody? I'll wait for your answer quickly. Hitzlsperger sign. It is seen in acoustic neuroma, also called as vestibular schwannoma. Very good, Bharat. Now, in the beginning of our discussion, we have learnt about acoustic neuroma while studying about Bill's bar. Yes, it originates in the internal auditory canal, acoustic neuroma. And this acoustic neuroma affects cranial nerves, the 5th cranial nerve, 7th cranial nerve, 9 and 10 also. But Hitzelberger sign is after its effect on the 7th cranial nerve, on the facial nerve. Now, facial nerve is giving sensory innervation to the external auditory canal. The posterior meatal wall is supplied by the facial nerve via its branch through the auricular branch of vagus nerve. And when the facial nerve is damaged in the acoustic neuroma, there is hypoesthesia felt in that region. Hypoesthesia of posterior meatal wall. And this is called as Hitzelberger sign. Is this clear to everybody? Okay, I'll move forward. Next is something called as Hennebert sign. What is Hennebert sign, anybody? It is a false positive fistula test. Can I repeat? What do you want me to repeat about hypoesthesia? Hitzelberger sign? See, the facial nerve is supplying, it's giving sensory nerve supply to the external auditory canal, to the posterior wall of the external auditory canal. Via the vagus nerve, via the Arnolds nerve, the facial nerve is sending its branch. Okay. And when the facial nerve is damaged, that area will receive less of sensations called as hypoesthesia because the facial nerve is damaged. And you elicit that sign. When you're suspicious that a patient is having acoustic neuroma, you try to check for the sensations on the posterior wall of external auditory canal because you know that area is supplied by facial nerve. And if at all facial nerve is damaged, there will be hypoesthesia in that region and that is called as Hitzelberger sign. Okay? Yeah. Coming back to Hennebert sign. What is Hennebert sign? It is a false positive fistula test. What is fistula test? We need to know. In fistula test, basically what we are trying to do is, we are trying to induce nystagmus in the patient by producing pressure changes in the external auditory canal. Okay? Now, in a normal person, when you change pressure in the external auditory canal, nystagmus does not occur. Okay, we are doing that in Jelly's test. We do it many times, right? We cause some pressure changes in the external auditory canal in various tests. And in a normal person, no nystagmus occurs. But if at all the person is having a fistula, then nystagmus will occur. So in a normal person, no nystagmus occurs. And fistula is said to be negative. Fistula test negative. But fistula test will be positive in certain scenarios where suppose there is some abnormal opening in the oval window, that is a fistula. Then what happens is, through that fistula, these pressure changes that we are creating in the external auditory canal, they are transmitted into the vestibular apparatus through this abnormal opening through the fistula. And then nystagmus occurs and that is called as positive fistula test. Okay, is the concept of fistula test clear to everybody? Now there is something called as false positive fistula test. What is this false positive fistula test? There is no fistula, but fistula test is positive. Why will that occur? It occurs in two scenarios. One is congenital syphilis. In congenital syphilis, the stapes is hypermobile. Now, a baby born to a syphilitic mother and who contracts syphilis will show various features, yes, such as your Hutchinson's tooth and so many features. And this hypermobile stapes is one such feature. And when the stapes is hypermobile, it will transmit these external auditory canal pressure changes into the vestibular system. Second scenario where you will see false positive fistula testis in Meniere's disease. In some patients of Meniere's disease, what will happen is there is a connection between the utricular macula. Utricle, you know, is a part of the vestibular apparatus. Yes, there is a connection between the utricular macula and the stapes footplate. So, whenever the stapes moves, the utricular macula is stimulated. And when it is stimulated, the patient shows nystagmus. There is no fistula, but nystagmus is occurring. Fistula test is positive. That is Henneberg sign. Is it clear to everybody? Now, what you must remember is Henneberg sign is seen in congenital syphilis. More than Meniere's disease, you have to remember congenital syphilis. How to remember? Let's make a story. Hen ne birth diya. The hen gave birth to a syphilitic child. Okay? Can a hen give birth? First of all, hens lay eggs. Forget about syphilitic child or a normal child. Okay? So this is a false statement that I have told you. It is a false positive test. Remember if it works, or make another way to remember yourself, but you have to remember. Okay, shall I move on to the next one? Is Henneberg sign clear to everybody? Okay. Next in my list is lighthouse effect. What is lighthouse effect and where is that seen? Lighthouse effect is seen in acute mastoiditis. What does lighthouse sign? In acute mastoiditis, there is ear discharge. Now, because it's an infectious condition, the discharge is either mucopurulent or purulent. Okay. This mucopurulent or purulent ear discharge is pulsatile. Okay. It is pulsatile. And it is seen coming out of a perforated tympanic membrane. This is also known as pulsatile otorrhea. Okay. Now, I'm assuming you know what a lighthouse is, right? Those tall towers or buildings that have a light on top. Yes, you know what a lighthouse is, right? They're present in the seas and oceans to help the ship captains to, navigate their way, or whenever there is some danger area, a lighthouse is put there. And that lighthouse will have a flashlight that keeps on, from a distance it looks as if some light is blinking. Okay, so this ear discharge looks like that lighthouse. Okay, it's not exactly an eponym, it's not the name of a scientist, but I thought it's a proper noun that that's worth remembering, and maybe it's slightly difficult to remember. That's why I've put it here. Okay. So the ear discharge that is coming out of the perforated tympanic membrane looks like this lighthouse effect. Okay? You must agree with me, doctors have great imagination and creativity. Can I move forward? Yes? Okay. Next in my list is a condition called as Lermoyer's syndrome. What is Lermoyer's syndrome? It is a variant of Meniere's disease. It's actually reverse Meniere's disease, I can call. Now, all the symptoms of Meniere's are present here also, but they're present in reverse order. Normally in Meniere's disease, what will happen? First, the patient has these episodes of vertigo, and then there is hearing loss. And after this entire thing settles down, the hearing loss also improves. That's why we say it is pulsatile hearing loss, on and off hearing loss. Okay. But in Lermoyer syndrome, what happens is, first there is hearing loss. Okay. There is progressive deterioration of hearing, followed by vertigo. So first hearing loss, then vertigo, then the hearing restores again. Okay. In Meniere's, it was vertigo followed by hearing loss, and then everything will restore. But here it is hearing loss followed by vertigo. This is Lermoyer syndrome in the simplest of terms. Okay. Now, this Lermoyer syndrome can be present in one of your options in an MCQ. Okay. Next in my list is Lux abscess. We have already learnt about basalt and Citley. Yes, now let's learn about Lux abscess. This is also seen as a complication of mastoiditis. Now in Lux abscess, the patient is not very lucky. What's happening? You cannot see an abscess or a swelling either on the neck or on the mastoid region or posteriorly, nowhere. The pus is breaking open, it's breaking open into the external auditory canal. That is Lux abscess. The pus breaks through the bony wall that is separating the mastoid antrum and the external auditory canal and forms an abscess there. So you can see Lux abscess in the bony part of external auditory canal. Okay. Next in my list is something called as Melchior-Son syndrome. Melchior-Son syndrome can be compared to Bell's palsy. It's an idiopathic condition of the facial nerve, and this is a triad actually. In this triad also we have facial paralysis. That is why I said you can compare it with Bell's palsy. Okay. Along with facial paralysis, there is swelling of lips plus fissured tongue. Okay. That is Melchior-Son syndrome. Now, such things, they can put it as a question, as a pictorial question. On one side, you will have features of facial paralysis, and then they will also show swelling of lips plus a fissured tongue. Now, that picture will immediately misguide you to Bell's palsy. The moment we see facial paralysis, facial asymmetry, we are so tuned to Bell's palsy that we do not even think of an alternate diagnosis. Swelling of lips also you might miss in the picture, but fissured tongue, if you see separately, that's a hint to you that it is Melchior-Son syndrome. Okay. Next. After Melchior-Son syndrome, I have a specific type of fever called as Pickett-Fens type of fever. Pickett-Fens type of fever. Where is the seen? It is seen in sigmoid sinus thrombosis. Okay. Now this is an irregular type of fever. What happens here is there is septicemia, and whenever the septic emboli will release those into the bloodstream, there is spike in the temperature. So this irregular type of fever is because there is a spike in temperature that coincides with the release of septic emboli into the bloodstream. That is Pickett-Fens type of fever. You will see some irregular pattern in the fever. It can be compared with malaria, but in malaria we have a regular duration, a specific duration of fever. But in Pickett-Fens fever, there is no specific duration, it is irregular. Whenever the septic emboli are released into the blood, fever occurs. A spike in the temperature occurs. Okay. But this Pickett-Fens type of fever, classical sign, it is not seen when the patient is on antibiotic therapy. Okay. So I can say this is kind of a historical interest, a sign that was once upon a time seen. But even now you can see this word in an MCQ. When they say Pickett-Fens type of fever, it's a hint that it could they're talking about sigmoid sinus thrombosis. Okay, next in my list is Phelps sign. What is Phelps sign and where is it seen? Phelps sign is seen in glomus jugular tumor. It is actually a radiological sign, just like our delta sign. This is also a radiological sign that is seen on CCT. What exactly are you seeing? There is a bony crest normally between the jugular bulb and the internal carotid artery, and that is absent in Phelps sign. Absence of the jugular crest absence of bony crest. Absence of the bony crest between jugular vein, jugular bulb and internal carotid artery. Is Phelps sign clear to everybody? Is the pace okay? Am I moving fast or is everything okay? All good? Okay. Next, after Phelps, I have something called as pulsation sign. What is pulsation sign? We have already discussed pulsation sign, and I gave you another name and told it's also called pulsation sign. Anybody quickly answer? What is pulsation sign and where is it seen? I'll move to the next one meanwhile. Paracusis willisi is the next one on my list. What is paracusis willisi and where is it seen? It is seen in otosclerosis. Paracusis willisi means hearing better in noisy environment than in quiet surroundings. Paradoxical hearing. Normal person will hear better when the environment is quiet and calm. But a patient of otosclerosis, because of the conductive type of hearing loss, will hear better in noisy surrounding. Why? In noisy surroundings, people will speak in a louder volume. So they tend to hear better. That is paracusis willisi. hearing better in noisy surroundings. Than calm environment. Very good. Akanksha, Bharat and Hamsika, all of you have answered. Pulsation sign is nothing but Brown sign. And that is seen in glomus tumor. We have written it before. Remember, for the rest who didn't answer the question, Brown sign, pulsation sign, seen in glomus tumor. When you increase the pressure in external auditory canal, what's happening? The tumor pulsates vigorously and then blanches. That is pulsation sign. Okay. Understood paracusis willisii? Can I move forward? Okay. Next sign is called as rising sun sign, or it's also called as red reflex. Where is it seen and what is it? This sign is also seen in a glomus tumor. And what is it? It is the appearance of tympanic membrane in glomus tumor. What happens is, because of the presence of a red vascular mass, that is the glomus tumor, behind the tympanic membrane, you can see some red sign on the tympanic membrane which is called as red reflex. It appears like a rising sun. Okay, that is rising sun sign or red reflex sign. It is the appearance of tympanic membrane that is described as rising sun. Okay, and why does it appear like that? Because of the presence of vascular tissue behind the tympanic membrane. Next in my list is Ramsay-Hunt syndrome. Another very popular disease, Ramsay-Hunt syndrome. Even if you haven't seen a case of Ramsay-Hunt syndrome, almost everybody must have studied about Ramsay-Hunt syndrome. Yes, what is Ramsay-Hunt syndrome? It is reactivation of the herpes zoster in the geniculate ganglion. Yes, reactivation of herpes zoster in the geniculate ganglion. Geniculate ganglion is a ganglion of which nerve? Basic question, but still, facial nerve. Okay. And what are the clinical features of Ramsay-Hunt syndrome? You will see facial palsy. Plus, most importantly, you will see a vesicular rash in the area that is supplied by the facial nerve. What is that area? Vesicular rash in the external auditory canal and pinna. That is Ramsay-Hunt syndrome. Now, facial palsy is not always Bell's palsy. We have understood that, right? If you see vesicles along with facial palsy, it's Ramsay-Hunt syndrome. If you see swelling of lips and also fissure tongue, what is it? Melchior-Son syndrome. Yes. Okay. After Ramsay-Hunt syndrome, the next sign is Schwartz sign. What is Schwartz sign, anybody? And where is it seen? It is seen in otosclerosis or otospongiosis. And what is it? It is a reddish hue that is seen on the tympanic membrane. It's actually seen on the promontory through the tympanic membrane. Now, because the tympanic membrane is a semi-transparent structure, you can see the changes inside the middle ear that are happening. So, it's a reddish hue seen on the promontory through the tympanic membrane. Okay. And this indicates an active focus of disease. Now, otosclerosis can be in an active phase or in a passive phase. If you see a reddish hue, it indicates that the disease is in the active state. Active focus of disease is there with vascularity, increasing vascularity. That is Schwartz sign. How do you remember? Schwartz, S for sclerosis or spongiosis. And you have gone for a war. And what happens in war? Red and blood. So there is reddish hue. I can show you Schwartz sign via a picture. This is the reddish hue that you are seeing. I hope you can appreciate. This is Schwartz sign. And also we have been talking about sigil speculum multiple times, right? That it is used to increase or decrease pressure in the external auditory canal. This is how a sigil speculum looks. This is a sigil speculum. Sigil is an eponym in itself, right? Where all do we use? We use it in the fistula test. We use it in Jelly's test. We see that in aquinosign. We use sigil speculum to elicit aquinosign. Yes? Okay, so this is how a sigil speculum looks like. All right. So next in our list, yes, Akash, you're right, a sigil speculum is used to cause pressure changes. Okay. So next in our list is something called as Tullio phenomenon. What is Tullio phenomenon and where is it seen? First, I'll tell you what that is and I'll see if you can answer it. Okay. It is a vertigo that is produced due to loud sounds or noises. Vertigo produced due to loud sounds or noises. That is Tullio phenomenon. And where do we see Tullio phenomenon? Where do we see this? Vertigo due to loud sounds. If you have been listening to the class attentively from the beginning, I'm sure you know the answer for this because we have discussed this condition and this test. Not the test, this phenomenon. Yes? So I will wait for your answer. The next one, meanwhile, is Toby-Ayer test. What is Toby-Ayer test? This is seen in or done in sigmoid sinus thrombosis. What this is you're seeing the effect of manually compressing the jugular veins and seeing that effect on CSF pressure. You will measure the CSF pressure with a manometer. Now, in a normal healthy person, if you press the jugular veins, if you compress the jugular veins, there is increase in the CSF pressure. Rapid rise in CSF pressure will occur. But on the thrombosed sigmoid sinus, this effect is not seen. So what is Toby-Ayer test? You're basically trying to see the effect of compression of jugular veins on CSF pressure. And what happens? Healthy side, the CSF pressure rises, and on the thrombosed side, there is no effect. This is Toby-Ayer test. Okay. Let me look at how many have answered. Akash says Tullio phenomenon is seen in men. Somebody says Macy. Somebody says Menders. Somebody says Lermois. Why Lermois? Why have you forgotten about Meniere's and gone to Lermois, which is the reverse of Meniere's? We have seen a question, remember? While we were learning about Donaldsons Line. It was a case of Meniere's disease, and in one of the symptoms, one of the clinical features was the patient has episodes of vertigo that are precipitated by loud sounds or noises. That's where I've made this mention. Tullio phenomenon is seen in Meniere's disease. Why does this peculiar phenomenon occur? What has the loud sound to do with vertigo? The distended saccule in Meniere's disease, endolymphatic hydrops, the saccule is distended and that lies against the stapes footplate. And so when the stapes footplate is vibrating, this will get stimulated and it causes vertigo. Why does it occur? Because of the distended saccule lying against the stapes footplate. Okay. Is Tullio phenomenon clear to everybody? Is Toby-Ayer's test also clear? Let me move on to the next one, and that is Tumarkin's otolytic crisis. Tumarkin's otolytic crisis. What is it? This is also a variant of Meniere's disease, just like Lermois. It's a variant of Meniere's. And what's happening in this disease is the patient suddenly drops onto the ground. There is a sudden drop attack without loss of consciousness or without any vertigo. Just like that, the patient suddenly falls. There is no vertigo, no loss of consciousness, no fluctuating hearing loss, no other symptoms of Meniere's disease. But the patient just falls down like that, as if the patient feels someone has pushed him to the ground. That is Tumarkin's otolytic crisis. It's also called as drop attacks. The patient has these attacks of dropping down. How do you remember? The patient feels, I told you, as if somebody has pushed him to the ground. So, किसी ने patient को मारा है. Somebody has beaten the patient. Tumarkin's otolytic crisis, and it is a crisis because the patient has fallen down. Okay? You want me to repeat Lermois syndrome? See, Lermois is same features as Meniere's, but they are occurring in reverse order. In Meniere's syndrome, what happens is, first there is vertigo, then there is hearing loss. In Lermois, first there is hearing loss, then there is vertigo. Okay, it's as simple as that. Understood Tumarkin's otolytic crisis also? And then in my list is Van der Hoef syndrome. Van der Hoef syndrome is actually a triad of three things, that is osteogenesis imperfecta, blue sclera, and the third one is the ENT condition. Why am I discussing Van der Hoff syndrome in ear? Because of the third one. What is the third one? Anybody? Anybody, what is the third one? It is otosclerosis. These three, if they occur together, it is called as Van der Hoff syndrome. Okay? Alright. Next in the list is Verroque body. Verroque bodies. Where are Verroque bodies seen? Even if you do not know ENT, you must have studied it in pathology. This is actually seen in the histopathological examination of acoustic neuroma. What else have we learned about acoustic neuroma? We have learned about Hitzelberger sign. Okay, good. So in acoustic neuroma histopathology, you will see two types of patterns that are called as Antony A pattern and Antony B pattern. Okay. This Antony A pattern is where the cells are tightly packed. And then in Antony B pattern, there is loose arrangement. Okay. In Antony A pattern, we observe Verroque bodies. What exactly are Verroque bodies? They are two parallel rows of palisading nuclei. Now, you could be given a picture showing Verroque bodies like this. This is a histopathological examination. Can you appreciate two different types of patterns? There is one type of pattern seen here, and there's another type of pattern seen here. Yes? Able to appreciate? Antony A and Antony B. So this is how a histopathological pattern of acoustic neuroma would look like. And there's one more important radiological sign in acoustic neuroma, and that is the ice cream cone appearance that you see in MRI. It is actually the best test. Okay, and this is an MRI, and where's the ice cream cone? This is the ice cream cone. This is the ice cream cone that you are seeing here. It is seen in acoustic neuroma. Now, you could be shown a histopathological image or a radiological image with some clinical features of acoustic neuroma, and they could ask you to diagnose, or they could ask you what exactly is seen there. Instead of naming it as Verroque bodies, they can ask you what is the histopathological sign that you see, or they can ask you what is the radiological sign that you see, or just a mention of ice cream cone appearance could be there. You know, various ways of asking the question. So this is, yes, Antony B is hypocellular, and acoustic neuroma is a tumor of cerebellopontine angle. Not cerebropontine, Akash, it is cerebellopontine. It is between cerebellum and pons. And the last disease in today's list of eponyms class is Wrinkler's disease. What is Wrinkler's disease? It is another name for chondrodermatitis nodularis chronica helicis. Chondrodermatitis nodularis, chronica, helicis. It's just a fancy name. Basically, what they're trying to say in simple English is benign inflammatory nodules are seen on the helix of the external ear, on the pinna. It's a benign inflammatory condition, first of all. It's a benign inflammatory condition. Where you see nodules on the helix, most commonly on the helix of pinna. That is Winkler's disease. Okay. So with this, I complete all the important eponyms of ear. We have discussed so many in the normal anatomical section and tests, and many more pathological signs. Especially in the pathological section, each one of them is a potential MCQ. It's a question that could be asked and that you could see actually in patients also. Okay, so do revise this entire session again, and I will quickly summarize just a few things for you in the reverse order now. Okay, in otosclerosis, what are some of the signs that we have seen? Carhart's notch, dip at 2000 Hertz, Schwartz sign, war, reddish hue on the tympanic membrane, Paracelsus Willis sign. Able to recollect? Okay. What have we seen in acoustic neuroma? We have seen Hitzelberger sign, ice cream cone appearance, and Verroque bodies. Okay. What else? A glomus tumor. So many signs in glomus tumor, right? Brown sign, rising sun sign. Yes, and many, many more actually. Okay. We have seen various abscesses, and also we have seen many in sigmoid sinus thrombosis. Crowley-Beck test, Toby-Ayer test. All these were seen in sigmoid sinus thrombosis. Yes? Now you might ask me, ma'am, you could have just explained it in a simple way like this, taking otosclerosis and all the signs seen in that, or taking, sigmoid sinus thrombosis and all the signs seen in that. No, I have intentionally juggled everything like this because in the exam, you will not be asked in a serial order like that. This ability to shuffle between topics is very, very, very important. In any exam that you take, suppose there are five questions from ENT, you will not get them in an order. Say first question from anatomy of ear, second question from middle ear, third question from inner ear. No, that's not how questions are asked. You should have this ability to shuffle between topics. So first, learn to shuffle between questions in the same subject, and then you should actually be able to shuffle between all the 19 subjects, and that's how your mind should work. Okay, so for that reason, I've put things at different places so that now, see, when you learn about ice cream cone, you will also revise about Hitzelberger sign. Yes, when we are learning about Paracelsus Willis sign, you will also think about Carhart's notch. That sort of thinking you have to develop. I've seen the sign. What else I have learned about this disease before? Okay, so that was the idea. And also, as I told you, these are present in alphabetical order. So you can, search for whatever you want later on also. So, is everything clear? Now, along with eponyms, there's another point that I want to drive in through this class, and that is eponyms are normally thought to be very difficult to memorize and learn, as I've told in the intro. But see, haven't we learned all the eponyms in a fun-filled way? I'm sure you can remember most of them now by some silly stories that I've told you, or by some mnemonics or whatever. Now, if such a grueling and grinding topic like eponyms could be learned, anything can be learned, isn't it? There is a way to learn anything, and you should figure out that way. That is important. Because learning for medical students doesn't end with a single exam or with an entrance test. It's a lifelong process. So we have to figure out how to learn and enjoy and continue that process. So continue studying, continue learning until you see your own name in the eponyms list one day, and the generations to come should curse you for not being able to remember that name and that sign. Okay, so on a lighter note, to end this class, you have seen a picture during the waiting time, right? How many of you saw? There was an examiner and a student sitting in a viva scenario. So I have asked about Greisinger syndrome, Grad-Inigo syndrome, Greisinger sign, and Grizzle syndrome. Yes? So found answers to all of them? Yes, Greisinger is seen in sigmoid sinus thrombosis. Grad-Inigo is seen in petrositis. And Grizzle syndrome I have not answered because it is not a part of ear. So search for that answer and put it in the comments, and also wait for more such things when we are discussing about eponyms of nose and pharynx and larynx in the coming sessions. So this is about ear. Let's also do the nose and throat in the next session. Until then, take care. See you all. Bye-bye.